Hello, welcome everyone to join us today for the third episode of MedLink Global Rounds. To those who joined us last week, I want to apologize again for the rescheduling, but more importantly, we're all here today. So today's topic is treatment of psychosis in 2025. We're very honored to have two experts joining us as speakers, Dr. Jonathan Meyer and Dr. Leslie Sintrom, alongside my co-host and moderator of the panel today, Dr. Christoph Correll, a globally recognized leader in psychiatric research and clinical practice. We will dive soon into the latest advance in psychosis, moving beyond the traditional approaches. So, without further ado, I would love to pass it over to Christoph and start the discussion today.
Great. Thanks so much, Rand. Thank you all for joining. And I'm really pleased to do this together with Jonathan and Les, two of my great friends and colleagues who have so much knowledge about this topic, schizophrenia and the new coming agents, and actually some of the revolution that has arrived already. But let's have them introduce themselves quickly before we go right into the meat. Jonathan?
Hi, I'm Jonathan Meyer. I'm a voluntary clinical professor of psychiatry at University of California, San Diego. And one of my main jobs is as a psychopharmacology consultant to the state hospital system in California.
Thank you. Les?
Hi, I'm Les Citrom. I'm a psychiatrist originally from New York, where I worked for the New York State Office of Mental Health and ran an inpatient unit dedicated to research and evaluation, and mainly in people with schizophrenia. I now live in Chicago, and actually for a while, I've been a consultant in the development and interpretation of clinical trials and serve as a consultant to an assertive community treatment team.
Great. Next slide. Let's review briefly what we think we know and don't know about schizophrenia and the pathophysiology and how that actually is relevant to the drugs we'll be talking about.
Yeah, so for a long time, schizophrenia appeared kind of mysterious, and we saw that no two patients are alike, and there's an array of different symptoms they can present with. But we've had a better appreciation of the emergence of negative symptoms and cognitive impairment actually before the onset of positive psychotic symptoms. So this led to some thinking exactly what is going on here, and it seems to be an imbalance in the regulation of dopamine in various parts of the brain. With too little in one part, too much in another. And there's a mismatch here leading to the different kinds of symptoms. So inadequate amounts of dopamine, neurotransmissions, for lack of another word to say it, in the cortex can lead to problems with memory, problems with attention, and also some emotional problems, and also negative symptoms or lack of desire in much of anything. And then in the striatum, too much dopamine yields positive psychotic symptoms. And we know that there's some genetic vulnerability to developing schizophrenia. We know that identical twins may not be so identical in terms of the development of schizophrenia. And we know also there's an inflammatory process going on, and the influence of stress also plays a role here because people have different degrees of resilience. So the main topic that we're going to talk about today, where do we focus our attention? For years, we've been blocking dopamine receptors themselves, which leads to problems, as we'll discuss. And maybe there's another way of altering the production, synthesis, so to speak, and release of dopamine earlier on in the right places selectively.
Absolutely. Next slide. Now, Jonathan, we've heard so much about the limbic system being the seat of psychosis. Has something changed?
Well, that was all based on animal models. And for those of you who've learned about the mesolimbic pathway, it's true in the animal model where there's dopamine overactivity associated with the animal equivalent of positive symptoms in the mesolimbic pathway, which involves the ventral tegmental area. going to the ventral striatum. But we can now image human beings with schizophrenia, and what we see is that the dopamine overproduction, which underlies positive symptoms for most people with schizophrenia, doesn't occur in the mesolimbic pathway, but in a more central part of the striatum called the associative or adjacent portion of the sensory motor striatum. I think, not to confuse you too much though, the simple concept is for people who are not treatment resistant, we see dopamine overproduction underlying their positive symptoms. And this is why, of course, in the past, when we tried to manage positive symptoms, we used things which blocked dopamine postsynaptically.
Great. Ren, 2 slides up, and maybe, Les, you can review this one more. What happened with this non-selective dopamine blockade? Where did it work and where didn't it work so well?
Well, our antipsychotics, be them first or second generation, have affinity to postsynaptic D2 receptors, and they work essentially as antagonists. Even the partial agonists are essentially antagonists in the conditions of the brains of people with schizophrenia. And basically, in the part of the striatum that explains hallucinations and delusions, it does its job. So this is the nigrostriatal pathway that Jonathan just mentioned, going from part of the substantia nigra that we didn't think before was associated with psychosis, but in humans it is, going to that part of the striatum that we didn't think was associated with psychosis, but now it is. So suffice to say, there is this pathway from somewhere in the brain to somewhere in the striatum that has too much dopamine going into the striatum. This pathway leads to excess dopamine stimulation of these postsynaptic D2 receptors in that part of the striatum that explains psychosis. So we can block those receptors, certainly. But when you block D2 receptors one place, you block them everywhere, and you have collateral damage. And what we know about antipsychotics, particularly the typical or first generation antipsychotics, we block with some gusto the nigrostriatal pathway that explains movement disorders. So we end up with dystonia, akathisia, rigidity, tremor, ultimately dyskinesias that emerge later on. So the atypical antipsychotics decreased this stimulation into this part of the circuitry that controls movements, but not perfectly so. And then you have a variety of different affinities to and action at the tuberoinfundibular hypothalamic pathway with some of our antipsychotics, even the second generation antipsychotics, increasing levels of prolactin. And then, of course, we're going to have some influence on the other pathways like the mesocortical pathway, which gets a little more complicated because we're not talking exclusively about D2 there. And there's some other influences that we have tried to target with newer medicines. But this is not a winning strategy, right? You can't unselectively block dopamine D2 receptors and expect to get away with it.
Jonathan, next slide. You are not only an expert psychopharmacologist, you're also a history buff. And now we are both here on one slide. Lead us through the story of muscarinic agonism.
Well, I just want to give you a historical perspective on dopamine. Our understanding of the dopamine, quote, hypothesis of schizophrenia was really reverse engineering by Arvid Carlson about how a medicine which made positive symptoms better also caused drug-induced Parkinsonism. And that's where that paradigm became predominant. But it was not the only idea out there. And in the late 50s, there were investigators using muscarinic agonists. These are cholinergic agonists at muscarinic receptors in both animal models and then also in humans, noting that it improved the symptoms of schizophrenia and created what was called lucid intervals. The problem is 1957 was probably the wrong time to be touting ideas about schizophrenia that did not involve dopamine. And this is when chlorpromazine, all the phenothiazines were approved shortly thereafter, other D2 blockers. And you can see in the literature, any comments about this were really lost. I mean, this was an important idea. It clearly worked, but it was lost in the mists of history as the dopamine paradigm became predominant in treating symptoms. But fortuitously, a compound was developed called xanomeline, which was intended as a muscarinic agonist to make people with dementia of the Alzheimer's type were cognitively intact. And it had fortuitous antipsychotic effects. And our whole portion of the lecture over the next probably 20 minutes is going to talk about really the reverse engineering of how a drug which stimulates M1 and M4 receptors, has no D2 binding whatsoever, could possibly be an antipsychotic.
Excellent. Thank you. Next slide. Now, as you've already heard, xanomeline is an M1, M4 agonist, and we'll hear much more about what that means. Let's go to the next slide. Before we do that, let's understand the muscarinic system. Les, can you lead us through that?
Well, there are 5 basic muscarinic receptors that we have recognized. It's not the only acetylcholine receptor. You may have heard about nicotinic receptors, which are different. Here we're focused on G protein related receptors, and we call them muscarinic. They're involved in a variety of human bodily functions, including our cardiac function, smooth muscle contraction, exocrine gland secretion, as well as centrally with learning and memory. And they're divided into 2 broad categories, excitatory and inhibitory. And by convention, the odd-numbered muscarinic receptors are excitatory. The even-numbered muscarinic receptors are inhibitory. But that's a little bit deceiving, because the even-numbered muscarinic receptors are actually autoreceptors. So their functioning is regulatory to tampen down the release of acetylcholine in the acetylcholine neurons. We can actually develop drugs that bind to the site where acetylcholine goes, or to an allosteric site, a site that's separate, that increases the activity of that receptor. Both methods can be done in terms of a drug target. And we're going to see an example of a success story here. As you know, we can talk all day long about mechanisms and receptors, and unless we can show that it actually works in people, it's just a story. So the proof of the pudding is in the tasting, and you've heard me say this many, many times, and I look forward to talking more about that.
So let me get this straight, Les. So we have a stimulation, M1, M4 agonism, but downstream means something else. So if I stimulate the autoreceptor, I have less acetylcholine, and if I stimulate the M1 receptor, I have more acetylcholine. Now, Jonathan, next slide, can you show us what that actually means in the antipsychotic effect, both bottom up and top down?
Yeah, so actually what we need to keep in mind is this GABA interneuron, which connects glutamatergic neurons in the cortical regions. And basically, GABA interneurons are inhibitory. There's a thought that schizophrenia is related to NMDA receptor hypofunction. And so you have a insufficient inhibitory tone on the glutamatergic neuron that connects to the part of the brain that then goes to the striatum where dopamine is released. So glutamate drives dopaminergic neurons, and it's a problem if you don't inhibit them. So we have the sick GABA interneuron, so to speak. Well, fortunately for us, there are also M1 receptors located on the GABA interneuron. When you stimulate them, it increases the activity of the GABA interneuron, allowing it to inhibit the glutamatergic neuron down the chain, and the inhibition of that will result in ultimately less dopamine being released. Now, interestingly enough, this is very selective, and it goes just to the part of the striatum that explains hallucinations and delusions. So that's top down, cortex down. There's also bottom up. And I have to thank Jonathan for making me appreciate the lateral dorsal tegmentum, where I said to him, and he may remember this, who's going to want to know about the LDT, lateral dorsal tegmentum? This is too many initials that we are talking about, and no one's going to really get it, and it's not important. Actually, it's very important. So it's located in the hindbrain, this nucleus of acetylcholine neurons, and it connects actually to a circuit that drives dopamine output into that part of the striatum that we care about very selectively. And acetylcholine, there is increasing the activity of that pathway. Well, one way of dialing that down is the M4 autoreceptor. And we can shut down that hindbrain output to circuitry that drives up dopamine release in the striatum from the bottom up with M4 agonism. So we have a double method of decreasing activity in terms of release of dopamine in the striatum. There's of course other circuits that or mini circuits that we can talk about, such as intrastriatal connections. But for the most part, we can explain things by top down M1, bottom up M4, ultimately decreasing the amount of dopamine that's released where we want to and not where we don't want to.
Okay, so we are now talking not just dopamine postsynaptic blockade. We're not talking one receptor. It's an orchestration of multiple interactions. I'm sure the audience is lost by now. Jonathan, can you repeat this and maybe put it in your words in a brief fashion so that everybody gets it?
So using the animal terminology, we think there's too much dopamine release, in this case from the VTA, going to the nucleus accumbens underlying positive symptoms. That VTA gets a couple of inputs, and that's its normal physiology, one of which is a cholinergic input from LDT, and one's a glutamate input from a descending pathway from the prefrontal cortex. Well, it turns out we can tune down the cholinergic input from LDT with an M4 stimulating strategy, and that decreases presynaptic dopamine release. We can also do the same thing up in the prefrontal cortex by stimulating a brake, so to speak, a GABAergic interneuron, and that'll put a brake on the glutamate input to VTA. The whole point is we've always wanted to decrease presynaptic dopamine release because that was really the source of positive symptoms. We never really did that before. We just managed it. We mopped up the mess postsynaptically with D2 blockade, which, as Les says, goes everywhere and is non-selective. The beauty of this strategy is we're actually sort of treating positive symptoms at the source. We are tuning down presynaptic dopamine release, and most important, we're doing it selectively. So you're thinking, well, these drugs go everywhere in the body. How can they be selective? Well, it turns out that the cholinergic pathway, which stimulates a dopamine pathway in the motor area, is mostly regulated by M2 autoreceptors. So biologically, yes, these drugs go everywhere, but they don't affect dopamine output in the motor areas. So if you don't affect dopamine in the motor areas, you're not going to get motor symptoms. And because these drugs, which stimulate muscarinic receptors, are not D2 blockers, we don't get other off-target issues such as endocrine side effects.
So I get that's right. It's location, location, location. But Les, next slide, you said the proof of the pudding is in the tasting. This was a first tasting, a very small tasting, 10 patients on placebo, 10 patients on xanomeline, after Lily had shown something worked for psychosis in Alzheimer's, but it had so many side effects. Why didn't we get in 2008 a new agent into our hands? It took until 2024.
Well, it's a problem with the drug that you use leads to vomiting in 60% of the people you give it to. It's unacceptable. So there has to be a way of dialing down these GI pro-muscarinic side effects, which are unavoidable with a drug that goes everywhere and stimulates things we don't want stimulated. So this was a huge problem until someone figured out, can we give an antidote to this and dial down these GI side effects and yet still have effective action in the brain? So that was
And
very clever.
we'll get there in a minute, but that means, so we've already berated the dopamine blockers as being indiscriminate and blocking dopamine everywhere. Now we have the same problem with xanomeline going everywhere and stimulating these cholinergic receptors. So we won anything? Well, Jonathan, show us what happened, what Les just alluded to on the next slide.
I think one thing we can say is a big win is not giving people movement disorders, some of which may be permanent, like tardive dyskinesia. But as you say, in this case, we have some off-target pro-cholinergic adverse effects. And some clever people said, you know what? Let's find a peripherally restricted anticholinergic. And the reason why I say peripherally restricted is xanomeline wants to stimulate muscarinic receptors in the brain. If you gave it with an anticholinergic, which gets into the brain, it would interfere with the mechanism of action of xanomeline. They found this compound, trospium, which has been around for 50 years, only about 20 in the US, but outside the US, which is a medicine for overactive bladder. It's a non selective muscarinic antagonist, but the beauty is it has very, very low CNS penetration. And that figure on the right, using a passive diffusion model, shows that among the medicines in that class of overactive bladder agents, it has extremely low crossing of a blood-brain barrier model. And that was the whole point. I can limit the procholinergic effects in the periphery without interfering with the mechanism of action in the CNS.
So let me get this right. We have two old drugs, 20 or more years old. We put them together and we have a revolution. That's like a marriage that creates a new king. Well, what is the bigger tasting? Next slide, Les. Tell us about the three emergent studies.
So these series of studies looked at this combination of xanomeline and trospium and compared them with placebo in acutely exacerbated patients with schizophrenia. And you would expect if it's going to work, it should work in this population, which has a baseline level of severity. So that's very important when constructing these studies. They were ill. Those who were randomized to placebo, as shown in the dashed line, showed some degree of improvement, as you would expect, putting someone in a structured environment like a hospital, giving them PRNs if they need them, and regular meals, and paying them, you're going to get some improvement. But look at the difference with those randomized to xanomeline and trospium. Much bigger treatment effect, starting at the first time point where this was assessed using the positive and negative syndrome scale, change thereof from baseline. The drug itself was titrated up in a forced titration model for the first 2 days, the lowest dose, and then 5 days at the intermediate dose. And by and large, you were expected on day 8 to go to the highest dose. There was the possibility of going back down in case of tolerability, but 80% or more of people randomized to xanomeline trospium combination stayed at the highest dose. So we don't have information from these studies about what's the best dose, but we have information about what happens when we give a completely new mechanism of action drug to someone who in the past would have only received a dopamine D2 receptor blocker. And we see improvements across the board when we look at the positive negative syndrome scale and look at different subscales and so on. The patients recruited in these studies are pretty much what we would expect in an acute schizophrenia trial. Average age about in the 40s, predominantly male, predominantly African American. This series of studies was conducted primarily in the United States, with one exception, with a limited number of patients participating from the Ukraine until the war interfered with that being done. So this is very interesting and totally unexpected in my eyes to have something this potent.
Great. Now, Jonathan, show us what the side effects were with this drug and what not the side effects. What were they not? Next slide.
Yeah, so I think one thing that's clear when you look at this, what don't you see? You don't see weight gain. You don't see the side effects related to elevated prolactin. You don't see movement disorders. We do still see some procholinergic adverse effects, but if you look at the rate of vomiting here, which is in the composite with 13.5%, this is a 75% reduction in the incidence compared to that early pilot trial, where, as Les said, the rate of vomiting was 60%. Xanomeline clearly did its work in limiting this. They are not absent. The point I do want to make, though, is that this is with the forced titration, which they use in the clinical trial with people who are markedly ill with mean PAN scores of 97. And as we'll discuss, in the practical use of xanomeline trospium, you may want to alter the titration because you might not be treating acute people with a PAN score of 97, and you may have the luxury of time to modify the titration. But this is what we get. We get some procholinergic adverse effects, some nausea, some vomiting, but also because of the trospium component in the periphery, some anticholinergic adverse effects such as constipation and dry mouth. I think the idea, though, is that, as Les said, this was very well tolerated. And I think the exciting part more than anything is that it was very effective.
Great. So this is 5 weeks. Let's go very quickly to save time for other content. Next slide. Over the long-term results. Efficacy for less, safety again for Jonathan.
Well, safety, of course, was the primary outcome in any open label long-term study, and it's done in order to satisfy an FDA requirement of a certain number of exposures at certain points in time. But typically, we also look at effectiveness or durability of effect and that sort of thing to reassure us that we're not going to see a recurrence of symptoms over time. And actually, what we see is a sustained improvement and actually marginal improvement over time. This is emergent for this recruited patients who were in the phase 3 acute studies, and those who were on placebo were then given a xanomeline trospium combination. Those who were on xanomeline trospium combination resumed their xanomeline trospium combination treatment. Everyone was retitrated in order to maintain the blind. What was evident here is 2 weeks after the open label phase began, those who were on placebo and switched over then to xanomeline trospium caught up nearly to their fellow patients who were on xanomeline trospium for 5 weeks. Didn't take very long to catch up. And both groups essentially did similarly in terms of reduction in PANSS total score throughout the remainder of the year. Now, fewer patients remained, of course, as time went on. These are observed cases, but it does reflect what we would expect in someone where we give a treatment that works acutely. We would expect it to continue to work long term, and we would expect some marginal degree of improvement over time. We've seen this in clinical practice for years. So this actually fits the mold here of an effective treatment that we would want to use. And when we look at the average PANSS score decrease, it was about 33 points for both groups, whether or not they had started in the acute trial on drug or on placebo. 33 points. So let's say you were at 95, ended up at 65. And for those listeners who aren't aware of what that means, a well functioning, as best they can person with schizophrenia is going to score around a 60 because they're not going to be free of all symptoms. And they will never be a score of 30, which is the lowest possible PANSS score. No one listening to this broadcast has a PANSS score of 30 because it's theoretical. We all have normal human emotions, and some of those are built in. So I'm very happy about this.
Great. Next slide, I will just go over it briefly. There were no surprises in the long-term safety, so we need to really save time here to get to the other content. Jonathan, tell us about the exciting news regarding cognition. Next slide.
Well, stimulating muscarinic receptors, we think, is a way to improve cognition. Obviously, xanomeline was designed specifically for that purpose. Now, these are exploratory analyses in people who were acutely psychotic. But what was exciting is that in all 3 of the pivotal emergent studies, we saw improvements in cognition, but, and this is the caveat, only in those who had low baseline cognitive function, meaning 1 standard deviation or Z-score, or even more so, 1.5 below norm. The average person who did not have significant cognitive impairment did not achieve benefit. We have not had anything in the world of psychiatry for schizophrenia, which has reproducibly improved cognition. We're pretty good at impairing it sometimes with anticholinergics and benzodiazepines or extensive D2 blockade. But this is very exciting and warrants further study in a dedicated cognitive trial of stable patients with significant cognitive impairment to see what the extent of improvement might be.
Great. Next slide. Let's tell us briefly about the ARISE program. Why is that done? When will it read out?
So we really want to know if we can combine treatments together and achieve a better result. 1 + 1 = 3 is our hope. 1 + 1 = 2, I'll take that. But right now, all we have is 1 + 1 = 1, maybe 1.1. So we want something that will boost antipsychotic effect. And it makes sense to combine drugs with different mechanisms of action. So this is a study that is currently underway that looks at the use of xanomeline trospium combination along with a antipsychotic. There are certain limitations there versus the antipsychotic alone. And the expectation is that we should see a larger degree of improvement with combo versus mono. It'll read out very, very soon. I understand that they're polishing up the remainder of the data, and I expect to hear about this soon.
And the difference is not titration to the maximum dose at day 8. No, it's week 4, which should also attenuate some of the side effects. But we've talked about xanomeline trospium as one agent. Jonathan, what about emraclidine? What is that? Next slide. And then what happened with it?
Well, we've sort of talked about that they had to find a solution to the procholinergic issues with xanomeline, which we think has to do with its broad muscarinic agonism. So the idea is, if we do a targeted M4 only strategy, could we avoid some of those procholinergic adverse effects, not have to worry about a slow titration? And that's why emraclidine was developed. It's a positive allosteric modulator, selective for M4. This is the phase 1b study. It looked positive. How exciting. And most importantly, nobody vomited. But as we will see on the next slide, the
Yes,
proof
go
of the
on.
pudding is a larger study.
Next
And when we
slide.
go to the next slide, we unfortunately saw that in these large phase 2 studies, we did not get separation from placebo really at any dose with no obvious dose response curve. And that's sad. We really hoped that perhaps an M4 selective strategy might solve some of the tolerability issues of xanomeline. And I think many of us would have been willing to maybe even swap out a little bit of efficacy for ease of use. So right now, the field is scratching its head and wondering, was this an emraclidine specific problem? Did they have not perhaps the right dose? Or do you really need both M1 and M4? And as of right now, we don't have an answer, but there's still a lot of companies looking at these strategies. And I think it still remains to be seen, could you still do an M4 selective strategy? We don't know, but I think we'll have some further data in the future.
Great. And Les, tell us about an M4 approach that did have some positive readout on the next slide.
Well, some positive and some not so positive. This was an M4 agonist, not a positive allosteric modulator, so it did not require that same degree of acetylcholine availability as a positive allosteric modulator. And what was surprising to me was, why would only one dose regimen appear to be efficacious, and why did the other 3 did not? So it remains to be seen. This was reasonably well tolerated. There was none of the typical muscarinic side effects that we are concerned about in terms of acceptability. There were some cardiovascular effects observed, which had been observed before with other drugs and using this strategy. So it remains to be seen what's going to happen next.
Great. And let's go to the next slide. What's going to happen next? Whoa, what a panoply of options. Jonathan, some words, not too many about this.
I think the idea is this is obviously an exciting area of treatment. We can give somebody something which will improve symptoms of schizophrenia without the D2 related adverse effects. And you can see lots of different combos, M4 only, M4, M1, agonists, positive allosteric modulators. All we can say is at this time, you'll need to learn how to use xanomeline trospium because these are still many years away from being in your hands if they're successful. But exciting area. We hope to have more options, but really, as a clinician, you have to learn how to work with the quirks of xanomeline trospium.
Great. Let's go to the next slide. Now it's applicability. How do we use xanomeline trospium, which is actually a BID dosed medication? We haven't really said that. And maybe Les, you can start the first half of the slide, and then Jonathan the second half, and give us our clinical pearls. What's the usability? Where would you use xanomeline trospium now?
Well, first off, as you mentioned, BID, what we also need to mention is without food, because in the presence of food, trospium is not adequately absorbed. So it's tricky to begin with, but we have lots of patients with residual symptoms where their current regimen is not adequate. We may consider this intervention as a monotherapy, but really, right now, lots of people are using it in combination, even though it wasn't studied in this manner, with the hope of getting better reduction in these residual positive symptoms. It may be useful where we really are very worried about some of the adverse effects of traditional antipsychotics. We may also think that maybe this will have a better effect on cognitive impairment associated with schizophrenia or negative symptoms in the long term. And then lastly, I want to mention something about the early phase patients, first episode patients. If they had in their hands the ability to take something that is not associated with the risk of tardive dyskinesia, that would be a huge plus. But it has to work well for them and it has to be adequately tolerated.
Jonathan?
Yeah, so the question is, why would you be going to this muscarinic strategy? Well, one instance, aside from efficacy, will be simply because of intolerable or unacceptable adverse effects. D2 related adverse effects motorically, endocrine, as well as some of the other baggage we get from the class of second generation agents, such as weight gain, metabolic abnormalities, sedation, and insomnia. I think the only point I want to make as a clinician is that this is a drug, xanomeline trospium, which will require sometimes several weeks to titrate, and you have to be mindful of that before pulling away the other agent completely and develop a cross titration strategy which allows the patient to remain stable. Now, we were very excited about the cognitive data from the acute trials. We need more data in stable patients to see if this effect is replicated. We really don't know if it's going to work in resistant schizophrenia. Resistant schizophrenia, when you image it, often is not associated with that dopamine turnover and excessive presynaptic release. That is how xanomeline works. Whether it really is a medicine for this, we don't know. I think the important aspect is if people are on anticholinergics, you can have two sets of problems. If it's a centrally acting anticholinergic like benztropine or diphenhydramine, well, you're going to need to taper that off because it'll interfere with the mechanism of action in the brain of xanomeline. But also, if you have any drug which is anticholinergic in the periphery, you can get additive effects with trospium. And you'll need to be mindful of this. And if you have people even on medicines for overactive bladder, you'll have to taper those off as you add xanomeline and trospium to avoid the combined anticholinergic burden in the periphery.
Great. Next slide. We've talked about briefly that treatment-resistant schizophrenia definitely needs more data with xanomeline trospium. There is another study program with evenamide that goes after the residual symptoms that are really more severe, even clozapine non-responders, and that's a positive symptom partial non-responder agent looking at a selective state-dependent inhibitor of sodium channels, which leaves actually the glutamatergic drive alone when it's at basal levels, but when it's stimulated, can drive it down. Next slide. There were very few side effects, and we're hopeful that the phase 2 study that was encouraging might read out in phase 3 also, because currently, except for clozapine, we don't have really anything available. Next slide. Also, cognition we've talked about. That is something that is still being pursued. Unfortunately, we've had 2 failures recently, eclapertin, a glycine 1 transporter inhibitor, as well as luvadaxistat, a DAAO, a D-amino acid oxidase inhibitor, both trying to enhance the coagonist, either D-serine or glycine in the synaptic cleft to drive NMDA glutamatergic functioning, where we want glutamate and dopamine for cognition, and that failed. There are other agents currently under development. Next slide. So we're in a new era, going beyond dopamine blockade postsynaptically. We haven't learned all that we need to learn. You guys using the medications, we are using it, what will happen, and also which other drugs come into our hands. Next slide. Let's wrap up with the summary. And maybe, Jonathan, you take the first 3 bullets, then less, and we'll see whether we have still time for some questions.
For one thing, schizophrenia is not just positive symptoms. It's a constellation of the core positive, negative, and cognitive symptoms with a lot of unmet need there. Being able to at least treat positive symptoms without the baggage of dopamine blockade is an enormous advance. Because of its mechanism of action, though, you need to learn how to use xanomeline trospium and avoid interactions with anticholinergics both centrally as well as peripherally. This will be the art of using a new medicine. Yes, it has its quirks, but most importantly, learn how to titrate it, learn how to avoid those drug-drug interactions. I think you might find that this is a medicine which does something very different than what we've used to been doing for the last 70 years.
Les?
So I'm looking forward to more data, including real world data of how this is actually used in which populations and what seems to be the best way to use it. Also, I'm curious about actually the cognitive impairment associated with schizophrenia angle, and also in other populations like psychosis associated with Alzheimer's, dementia, irritability, and aggression. So remains to be seen. I'm looking forward to the data.
Great. Thank you so much to the two of you. We have a little bit time for questions. The first one that's coming in as well. It's exciting to hear all of this. Hopefully, we can get such a therapeutic approach into Europe. And what about long-acting injectable formulations that are given for people who have trouble either remembering or wanting to take medication? What about illness insight? Do we have any information on the new agents? Where will they be when? And also, will there be an LAI? Anyone?
Well, with the LAI, it's a challenge. Even with what we have available today in terms of second generation antipsychotics, not all of them are amenable to be reformulated. Even the ones that appear to be good candidates, the medicinal chemist cannot come up with a product that, when injected, gets released in a predictable manner from the site in the muscle or under the skin. But stay tuned. Maybe we'll have other strategies and other technology to get this done. I don't think it's going to happen with combination drugs because that makes it even more complex. But once we have a single agent, not a combo, M1 or M4 or both, PAM or direct agonists or a combination thereof, that's simple, that's chemically able to be reformulated, I think it's going to be possible. I think we'll have it. It's just not tomorrow.
And the dosages in the 100 milligrams is most likely too much volume to be injected. We hope that the European regulators will not make it too hard for this new medication to come into our hands. As many of you know who may listen, that in Europe you need to not only have acute studies, but also relapse prevention studies read out positive. Often there's an active comparator needed, which we did not have here. So we have indirect indication that xanomeline trospium is quite effective, maybe at effect sizes like olanzapine or risperidone, but don't we also want active control studies?
I think that's important. And although we do have effect size, as you said, which are in the range that we haven't really seen for 30 years, it is important to have some head-to-head just to show that what we saw in the placebo-controlled trials is really replicated when you have an active comparator. I think it'll give people confidence that it's not just that they manage placebo response really well in the clinical trials, but that it really does stack up to the traditional strategy of non-selective postsynaptic D2 blockade.
So we don't have more time to go through questions. I want to just ask each of you to come up with like a final message, clinical pro, whatever you want to come up with. Les first, then Jonathan.
Well, I have a philosophy. If something doesn't work, you want to try something completely different. And up to now, we've had really drugs that are more similar than different. Now we have something really different. So I would try that.
Thank you.
This is the future of schizophrenia treatment. We've now seen a path forward outside of the box of D2 blockade. There will be other agents we hope in the future, but as I said before, for now, learn how to use this medicine, learn how to be flexible with titration, learn how to get rid of anticholinergic burden to minimize tolerability issues, because this mechanism offers something very unique that we've never had before, and a lot of patients will benefit from it, but only if you can get them on it and tolerate it.
Thank you. And I may add that obviously there's no panacea. There will also be people who don't respond to xanomeline trospium, as we've seen in the studies. And our current treatments will not go away. They've also been helpful for at least some patients, and some can tolerate the available drugs. I'm excited about rational polypharmacy because there's so much irrational polypharmacy, and that might bring people to a place where there couldn't be otherwise. So I want to thank you, Les Citrome, Jonathan Meyer, for this wonderful interaction discussion. We want to thank you, the audience, to either be here live or listen and look at this in the future when it's being streamed. And we're also grateful for everyone who has contributed to these data, whether it's patients and families, the pharmaceutical industry that's investing and getting into a risk here, investing into something that may not pan out. But we need these investments in order to have innovation. And hopefully there will be more innovation in the future that we can talk about. Maybe in half a year or a year, we'll meet back again and have maybe Schizophrenia 2026 soon and see what it brings to us and our patients. Thank you all. And maybe Ran, you want to wrap up for us?
Sure. Well, very engaging and insightful discussion. I learned a lot, and I'm sure the audience also learned a lot. I want to extend my deepest gratitude to all of you again for sharing your expertise and perspective in this emerging landscape of psychosis treatment. Before we go, I do want to have one more thing to say. Our beta program for minds, an innovative tool designed to help mental health professionals and primary care doctors to achieve comprehensive, accurate diagnosis without adding extra workload. Um, that's all for today. We look forward to continuing the discussion every month, and I hope to see you again soon, next month. Thank you.
Thank you. Bye.
Bye.
Hi, everybody.
Bye.